Hello, welcome people. In this video, let us look at this case study. A 56-year-old male presented with weakness. The age you look at, 56-year-old male presented with weakness, pallor, anorexia, loss of weight, pallor is there, massive splenomegaly, bone tenderness is present. Hemoglobin is 10, kind of anemic. WBCs are more than 1 lakh. Leukemia could be. Platelet count is kind of okay. Now look at the peripheral blood smear. This is a blood smear. As you can see, there are RBCs, so definitely it's a blood smear. These look like, this looks like a, what is this? Eosinophil. What is this? 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 Eosinophil. What are these? A lot of these are not lymphoid, these are all myeloid cells. What do you say? A myelocyte probably. So what and all makes the neutrophil, you know that, right? A promyelocyte becomes a myelocyte, metamyelocyte, band form, then neutrophil. These look like band forms. Okay, these look like band forms. Based on the color of the granules, you'll have to say whether it is a band form or a eosinophil. This actually looks like a band form more to me than an eosinophil. Myelocytes are something like this. Actually, this looks like a metamyelocyte. It's a little bean shaped, the nucleus, right? Wherever it is bean shaped, you can say it is a metamyelocyte. This one is a myelocyte. Let us say this is a metamyelocyte, then promyelocyte, etc. Okay, so all these are myeloid precursors. What are the questions? So definitely these precursors should not be there in the blood. They all have poured over to the blood. What is the diagnosis? Write 2 points in favor of your diagnosis. How do you differentiate it from leukemoid reaction? What is the chromosomal abnormality in this condition? It's not difficult. See, this diagnosis is definitely some myeloid leukemia. Whether it's chronic or acute, you can say it is chronic because here there are no hour rods. Okay. Then 2 points in favor, that's what we can say. Myeloid precursors are there, anemia is there, WBC count is more, then massive, then bone tenderness. How do you say it's chronic? Because hour rods are not present. Chromosomal abnormality will be Philadelphia chromosome, that is 9:22, right? How do you differentiate it from leukemoid reaction? Leukemoid reaction, the WBC count will be less than 1 lakh, right? So guys, in leukemoid reaction, what will happen against leukemoid and CML we are comparing now. Leukemoid reaction, what will happen? Better look at it here in a separate page. Leukemoid reaction is not leukemia. Remember, leukemoid reaction is not leukemia. You cannot term it as cancer. Now this is CML. The WBC count here will be less than 1 lakh. Here it will be greater than or equal to 1 lakh per microliter, 1 lakh cells per microliter. Now what about the differential leukocyte count? Here there will be polymorpho nuclear cells. That means there will be more mature cells. Here immature cells will be more. In CML, the immature, all maturation stages and immature cells actually are more. There will be more basophils also. Immature cells are more. Here also immature cells are there. Immature cells are there everywhere, but here immature cells are there more. Okay. So now what happens to the NAP score? That is neutrophil alkaline phosphatase. Here it will be elevated because more neutrophils obviously. Here in CML, as the immature cells are more, here it will be less. The NAP score will be reduced in CML. What about Philadelphia chromosome? It is present in CML. Obviously, if Philadelphia chromosome is present, then the BCR ABL fusion gene is present in CML. Then coming to etiology, why does this happen? Leukemoid reaction, in infections it can happen, that the normal WBC count is increasing. There can be some malignancy, disseminated malignancy, severe hemorrhage, intoxication can happen. In CML, what happens? This is oncogenic, so virus, etc. Oncogenic virus, this is not infection, oncogenic virus, some radiation, which all cause cancer. Then coming to what else you will see, anemia will be there in both. Anemia is there in both. Okay. Then platelet count is raised in both, they are saying. Raised platelet count. Platelet count is more. Normal to raised platelet count. Then myeloid hyperplasia, both are the same only. This is myeloid. Actually, this should be the first point. Both are going to be a myeloid hyperplasia only. So both are myeloid hyperplasia. Both are same, myeloid hyperplasia only. Okay. But they are mostly putting effect on the neutrophil side. Okay. What you have to do is infiltration. Infiltration is present in CML. Why it is present in CML? Because CML is cancer, right? And it is a malignancy. It's leukemia. So definitely infiltration is present. What about splenomegaly? Splenomegaly is massive. Actually, it is not just splenomegaly. It is massive splenomegaly is present in CML. So just go back here and see here in the case that is given, they are mentioning clearly that it is massive splenomegaly. Platelet count is around normal. WBC is greater than 1 lakh. Here you can see a lot of myeloid precursors. There are no hour rods. There is massive splenomegaly. So you can say loss of weight, etc. So it seems like a chronic condition. So chronic myeloid leukemia. 2 points in your favor we already mentioned. Differentiate from leukemoid reaction, we have differentiated. What is the chromosome abnormality? Let us focus on this chromosome abnormality now. Say Philadelphia. Oh, you're eating? Okay. Philadelphia chromosome. So Philadelphia chromosome will be translocation 922. Some Q something is there. Let's show that from our previous video. Wait. Okay, we'll go here. This was our previous lecture video. In this, yeah, the Philadelphia. Say Philadelphia. Philadelphia. So basically 922 BCR ABL fusion gene. Yes. So this is the Philadelphia chromosome. Okay, guys. So the splenomegaly is massive. You should not forget. Massive splenomegaly will be there in CML. There will be weight loss. That's why it is called as chronic condition. Chronic condition. Now in the blood picture, you can see that there are a lot of myelocytes and metamyelocytes. Lot of basophils can be there. Rising basophilia. So basically in chronic myeloid leukemia, you have chronic phase, accelerated phase, blastic phase. In blastic phase, the blasts are greater than 20%. Okay. Then what else? So 3 phases of CML you got, right? Chronic, accelerated. So just highlight these words. Okay. Chronic, accelerated phase, and then blastic phase. 3 phases are there. Blastic is looking more deadly here. Then if there is rising basophilia, it means to say that it's becoming blastic. In bone marrow, what will be there? Hypercellularity, less fat, myeloid erythroid ratio, myeloid ratio will be more, erythropoiesis, reduction in erythropoietic cells. There is reduction in erythropoietic cells. Less erythropoiesis, that is why there is anemia, correct? That is why there is anemia. Because all the effort it is putting to make those neutrophils only. Megakaryocytes are small in size. Platelets are small in size, at least that part they are sure. Then cytogenetics, you can detect by FISH PCR. Say FISH.
FISH PCR.
FISH is fluorescence.
FISH is fluorescence.
In situ.
In situ
hybridization.
hybridization.
Yes. This is why it happens CML is because of reciprocal translocation. Say reciprocal. Say reciprocal.
Reciprocal.
Reciprocal. This is because of all these cytogenetics. Then cytochemistry, the NAP score will be what? It will be less because immature cells are more. Then there can be gout, etc.
In inipal cells.
What did I say, baby? What are you trying to say?
Inipal cells.
I don't know. Okay. Then CML, what is the treatment? Imatinib. Okay.
Imatinib.
Yes. Okay, let's get back to the case study now.
Okay.
They asked us about Philadelphia chromosome. So, how do you differentiate from leukemoid reaction? Everything is over. So, diagnosis CML, 2 points in favor. Differentiate from leukemoid reaction, chromosomal abnormality in this condition, Philadelphia chromosome. We are done with the case study on CML. Say bye.
Bye.